Good morning. Thank you, Dr. Cassis, for the introduction. And we're going to talk about obstructive sleep apnea, which to me is near and dear to my heart. Acknowledgements. I am a consultant with Inspire Medical Systems, which is one of the technologies that I'll be speaking about this morning, and I serve on their physician advisory panel. I have no other conflicts to disclose. Our objectives today are to identify the prevalence, pathophysiology, and risk factors for obstructive sleep apnea, to discuss the sequelae of untreated obstructive sleep apnea, and to review the various treatment options available today for the treatment of obstructive sleep apnea. There have been many studies published looking at prevalence of obstructive sleep apnea. One of the landmark studies that was performed at the University of Wisconsin, where they essentially sampled a very large segment of the Wisconsin population at large who did not carry a diagnosis of sleep apnea. They had over 1,500 patients selected between the ages of 30 and 70. And then they did sleep studies on all of these people and found that the overall prevalence of sleep apnea in this population was 26%. But if we eliminate mild sleep apnea, which carries less health risk, still the incidence, or I should say the prevalence of moderate to severe obstructive sleep apnea, which is an apnea-hypopnea index greater than 15, was 10%. Furthermore, you can see a twice as high incidence of sleep apnea in men compared to women, with 13% of men having moderate to severe obstructive sleep apnea. Of this enormous segment of the population that has obstructive sleep apnea, the estimate is that about 75% is undiagnosed, and that includes severe sleep apnea. So, very high burden of disease in the population, and most people don't get diagnosed. So what happens during sleep apnea? Well, it is a function of how the throat works, in that we use our throat for both swallowing and breathing. And from an engineering perspective, that's kind of odd. We put everything in one hole, whether you're swallowing it or breathing in. And the problem is that when you swallow, the entire walls of the throat must collapse and squeeze to push the food into the esophagus, but when you breathe, it needs to be open. But this means that this tube that you're breathing through is collapsible. And during sleep apnea, the walls of the throat do collapse, obstructing the airway. It can collapse in the anterior-posterior dimension. It can also collapse from side to side in the lateral dimension. And many patients, about 50%, will have multiple levels of collapse in different parts of the throat. This doesn't occur during the day because of a couple of factors. One, you're usually upright, and two, muscle tone is much greater during the day, and so active muscle tone prevents the muscular walls from collapsing. The main dilator of the airway is the genioglossus muscle, which moves the tongue anteriorly, and it's been shown to have increased activity level during the daytime in patients with obstructive sleep apnea as a means of compensating for their poor airway. But this increased muscle tone of the genioglossus disappears once they fall asleep. Screening patients for sleep apnea is an important objective in primary care because, as you just saw from the previous slide, about 10% of your patients have moderate to severe obstructive sleep apnea, and most of them aren't diagnosed. One of the popular screening tools is called the Stop Bang questionnaire, and that's an acronym that includes asking if the patient snores loudly, are they tired or sleepy, are there observed apnea or choking episodes by sleeping partners, do they have elevated blood pressure, is their body mass index over 35, age greater than 50, a neck circumference over 16 centimeters, and male gender. These are all known risk factors for obstructive sleep apnea. Symptoms of obstructive sleep apnea are loud snoring, which is present in most but not all patients with obstructive sleep apnea, choking episodes at night, which may or may not wake the patient up but would be observed by a sleeping partner, insomnia. Paradoxically, many patients with obstructive sleep apnea actually have difficulty falling asleep or staying asleep. Having to get up to go to the bathroom at night, witnessed apnea, of course, difficulty with memory loss and cognitive impairment, depression and irritability, and decreased libido. This slide I would consider the most important slide for people to think about in this entire lecture, because this is, again, going back to that Wisconsin study where they looked at both overall mortality as well as risk of death from cardiovascular causes. And what you see plotted here is time. They followed patients up to 20 years in this study, and you see different cohorts. Each line here represents a different group. The top very light gray line shows people essentially who don't have sleep apnea with an AHI less than 5. You can see over the course of the 20 years, about 5% of them died for various reasons. Each line below that then represents mild, moderate, and severe obstructive sleep apnea with all-cause mortality. And what's striking is the patients with severe obstructive sleep apnea, approximately 40% of them died during the study, compared to about 5% of patients who did not have severe or did not have any sleep apnea. And so not diagnosing obstructive sleep apnea is very dangerous for the patient because it is likely to significantly affect both the quality as well as the longevity of their life. And just to give you one particular statistic, if we look at death from cardiovascular causes, the relative risk of dying from cardiovascular cause if you have severe untreated obstructive sleep apnea is 5 times higher than the general population. That's a 500% increased risk. Another important point on this slide is that the presence of sleepiness, so excessive daytime sleepiness or fatigue, did not correlate with outcomes. So for the patient who says, I don't have a sleeping problem, I feel fine during the day, we cannot then say, well, therefore your sleep apnea isn't going to exert a toll on your health. It's going to anyway, even if they're not sleepy. Oops. There are a lot of ways that obstructive sleep apnea contributes to heart disease. One of the biggest causes, it is thought, is the activation of the sympathetic nervous system. This has been documented in patients with obstructive sleep apnea. Specifically, with every apneic episode, there is a surge in catecholamine levels within the circulation, and this does everything you would expect catecholamines to do. It increases heart rate, cardiac output, peripheral vascular resistance, and also increases renal tubular sodium resorption. All of these will contribute to hypertension, and not just nocturnal. And there was a Mayo Clinic paper published that showed that untreated obstructive sleep apnea was as significant a risk factor for ischemic heart disease as obesity, smoking, and hypertension. Arrhythmias are extremely common in patients with obstructive sleep apnea, including bradyarrhythmias, but most of the time tachyarrhythmias such as atrial fibrillation. Obstructive sleep apnea is one of the leading causes of AFib, if not the leading cause. Pulmonary hypertension as well as diastolic dysfunction are seen in patients with untreated sleep apnea. There is an increased effective afterload of the left ventricle due to the decreased intrathoracic pressure during apneic events. There is also increased platelet activation and aggregation with reduced fibrinolytic activity, leading to increased risk of thrombosis, and there's increased oxidative stress with accelerated coronary artery disease. Therapy. Prior to CPAP, the only real therapy for obstructive sleep apnea was a tracheostomy. But in 1983, Sullivan introduced the concept of applying positive airway pressure to the patient during sleep, and that launched CPAP. This basically uses pressure, air pressure within the throat to stent the walls apart so that they don't collapse during sleep. And that prevents the sleep apnea. There are a number of variations of PAP therapy now. We have auto-PAP, where the PAP machine itself will vary the pressure to effectively eliminate their sleep apnea. There are multi-level or bi-level PAP units that give them a higher pressure during inhalation versus exhalation. And there's even something called adaptive servoventilation for patients who have central sleep apnea, which we won't go into. For patients who have very mild sleep apnea or who are intolerant of CPAP, there are alternatives. And the other non-surgical alternative for obstructive sleep apnea is use of an oral appliance. The most common oral appliance for sleep apnea is something called a mandibular advancement device, and there are about 100 of these on the market in the United States, and they are most effective for mild sleep apnea. If there is a patient who is intolerant of CPAP, you can use it for moderate to severe sleep apnea, but the probability that it will provide successful management of their sleep apnea is much less. Studies show mean reductions in AHI of anywhere from 30 to 70%, and an overall success rate anywhere from 45 to 100%, depending on which patient population you're treating. Compliance for oral appliances tends to be higher than CPAP, and can be as high as 80%. There are surgeries for obstructive sleep apnea, and to perform surgery for sleep apnea, we really need to identify and target the specific cause of obstruction, otherwise the surgery is not likely to be successful. There is no one single surgery for obstructive sleep apnea. Tonsillar enlargement, whether it's the adenoid, the palatine tonsils, or the lingual tonsils, can certainly cause sleep apnea, and if the patient has tonsillar hypertrophy, this is an excellent surgical treatment for sleep apnea. Palatal and lateral pharyngeal collapse can be treated with a procedure called a Uvulopalatopharyngoplasty to essentially stabilize the lateral pharyngeal walls, and there is also a procedure called expansion pharyngoplasty, which further widens the posterior pharynx. We'll talk a little bit about uvulopalatopharyngoplasty. This surgery was essentially described in the 1980s and became quite popular in the 90s until we realized that this is not effective for many patients because we weren't really selective in targeting the right patient group with this. It is still performed today, though, for the right patient. This consists of resection of a small amount of the distal soft palate and uvula, but in most surgeons' hands who are doing this procedure, there are a number of modifications that allow the lateral pharynx to be widened and stabilized for much better results. The results of this procedure are consistently better when a concurrent tonsillectomy is performed. So if a patient has already had a tonsillectomy performed, uvulopalatopharyngoplasty is usually not going to be a great option. The best patients for this surgery are patients who have larger tonsils, who are thinner, have a smaller tongue in a lower position in the mouth. One of the most recent developments for the treatment of obstructive sleep apnea with surgery is something called hypoglossal nerve stimulation. People use the term Inspire to describe this procedure, but Inspire is the device that is currently FDA approved for hypoglossal nerve stimulation in the United States, but hypoglossal nerve stimulation is really what the therapy is. And this involves placement of an electrode on the hypoglossal nerve and a pressure sensor in the chest wall musculature. And the system, when it detects inspiration, delivers an impulse to the hypoglossal nerve, causing the tongue to move forward. So we're activating that genioglossus muscle, which opens the airway posteriorly. This forward movement of the tongue also pulls the soft palate and the epiglottis forward through coupling, and that opens the entire upper airway from the palate to the epiglottis. The impulse, as I said, is synchronized with breathing because of the placement of the pressure sensor between two ribs in the intercostal space. And that way, the stimulus is only delivered during inhalation when the tongue moves forward, and during exhalation, the tongue relaxes. Um, can anybody play those videos? I don't have a laptop here. If we click on the first one. In this video, you can see a patient with obstructive sleep apnea at the level of the tongue base and epiglottis. You can see the tongue base and epiglottis completely obstructing the airway. The second panel, just stay up here, shows at a higher level in the throat behind the soft palate. You can see the soft palate is touching the posterior pharyngeal wall, which is at the top of the screen, and the soft palate is at the bottom of the screen. So that's looking at the airway from above in the nasopharynx. On the right side, we're showing with Inspire stimulation at the tongue base. There's stimulation. You can see the epiglottis and tongue move forward, and then it's off during exhalation. And then in the last panel, you can see at the level of the soft palate during stimulation, the soft palate is moving forward. Okay, thank you. It's not advancing now. Sorry about this. Okay. There have been a large number of papers already published in the last 10 years looking at the effectiveness of hypoglossal nerve stimulation therapy for obstructive sleep apnea. And the ADHERE registry, which I participate in, is a multinational, multi-institutional cohort of patients who have received the Inspire device for their obstructive sleep apnea. And results of the ADHERE registry have been published over the years. There's currently far more than the 300 patients that you see on the slide. It's in the thousands now. There's a couple thousand patients in the registry. But we see from the results of this registry that the mean apnea-hypopnea index decreased from 36 to 10, and the absolute AHI reduction was about 25, which is a 71% decrease. Success, which is defined as a reduction of AHI of greater than 50% and a final AHI below 20, is achieved in about 80%. Some patients will actually achieve, about 50% will achieve an AHI in the normal range, which is less than 5. Average use of Inspire per night is 6.5 hours, which is substantially greater than CPAP. And 90% of patients reported a better experience with Inspire than CPAP, and the overwhelming majority would do it again. Complications are quite rare and usually transient. It's not advancing again. That video messed it up. Criteria for receiving hypoglossal nerve stimulation therapy is moderate to severe sleep apnea, so an AHI between 15 and 65, a BMI less than 35, adults greater than 18 unless the patient has Down syndrome, intolerance or noncompliance with CPAP. They must have a recent sleep study within the past couple of years. Central sleep apnea cannot represent more than 25% of their total AHI, and they cannot have something we call complete concentric collapse of the airway at the level of the soft palate on sleep endoscopy. Future developments are evolving rapidly with this type of therapy, and I think that over the next 5 to 10 years, we're going to see tremendous advances in the management of obstructive sleep apnea. One advance is going to be our improved ability to phenotype, meaning place patients into different groups based on physiologic or anatomical criteria to really optimize selection for these procedures. In addition to Inspire, there are other systems that are currently in development. I've mentioned a couple right here that will be things that we'll be considering over the next couple of years. And there may be other nerves that we begin to stimulate, like the ansa cervicalis nerve, to actually stimulate the strap muscles and stabilize the lateral pharyngeal walls. That's it. Thank you. We just received a question that I'll go ahead and answer. The question is, does this therapy result in any discomfort? The answer is generally no. The hypoglossal nerve is a motor nerve, so it does not have any sensory fibers, so there's really no direct perception of pain with therapy. Overstimulation of the nerve can be uncomfortable, and we don't want to do that, but as long as the stimulus level is set in a comfortable level for the patient, it is not uncomfortable. Occasionally, someone will find some soreness on the side of their tongue if their tongue is rubbing against their teeth as it moves back and forth. This is not a common problem and usually goes away over time, but the therapy itself is not painful or uncomfortable.